Am I audible?
Yes, you are
Yes, sir.
audible. And
Okay, so my slides are visible. So greetings from India. Thanks for giving me this opportunity to be here today. So I will keep my talk very brief and to the point. And today I will be talking on molecule profiling in colorectal cancer. When, what, and why. So we know the biomarkers have evolved in other cancers also. So is the scenario in colorectal cancers also. So until recently, we had RAS mutations, which remained the only genomic biomarker to assist with the therapy selection in metastatic colorectal cancer. But now, with liquid biopsies and genetic um, sequencing, next generation sequencing coming in, we have potentially more powerful predictive genomic markers also. Uh, so if we look at the metastatic, if we look at the evolving field in the metastatic setting in the colorectal cancers, we see there is a lot of development. There are a lot of molecular profiles which we are developing as of today. Then again, we have come to know that a tumor right and left, there is a difference. Sidedness plays an important role in choosing the treatment modalities, also in planning the treatment and in the outcomes. The same is true that we know that the immune activity and the microenvironment also plays a role in choosing and predicting the therapies. The same is true that we know that these mutations, many of these mutations are dynamic. That is, they change. They are not static. That also we will discuss. So the first question is when to do the molecular testing and what. So if we look at the guidelines as proposed by NCCN in colon and in rectum, both, in non-metastatic setting, what is standard as of now is the MMR and MSI testing, which is to be done at this point of time. So this is the standard recommendation. So once we move from the localized cancer to the metastatic setting, the things change. So what are the changes? Here, if we can see here, they say we need to test the tumor for the RAS and the RAF mutations and also for the HER2 amplifications. Either we can do this individually or we can do it as part of the next generation sequencing. And obviously, MMR and MSI testing is required. If it is not done earlier, it needs to be done. So implication that we will discuss later. So what we need to test, when we have seen indirectly, we also know what we need to test. We know that the colorectal cancer is a heterogeneous disease. It does not represent a uniform disease. And as per the consensus molecular subtypes, it is consists of four different histologies, four different types or subgroups. Each differs molecularly in the molecular signatures and other characteristics. So this is just to show that the BRAF mutations are more in CMS, MSI immune status high patients, and KRAS is there in the metabolic type. And again, there is subset which we cannot determine which subgroup they will fall into. So we have, it's a highly heterogeneous group of disease. So tumor sidedness, again, as I said, colon cancer is not one entity. It is different embryologically, it is different molecularly. So there is a difference in the right and the left-sided tumors. Since it is different embryologically, there is difference in the molecular markers also in the right versus left. That also we will see. The tumor sidedness again has emerged as a prognostic and predictive biomarker in metastatic colorectal cancer. We know very well that EGFR inhibitor therapies, they don't work well in the right-sided tumors. It is both prognostic and predictive. So this is how it is different. The molecular mutations present on the right and the left, they are different. And there are high rates of mutation which are present in the right-sided tumor as compared to the left-sided tumors. So again, the same thing. If we look at the different subgroups, we can see in the right versus the left tumors, there is a different prevalence of the genes is there. And APC, it is almost equally expressed, but more in left-sided tumors. TP53 mutations are more common in left-sided tumors, KRAS is almost equally distributed. Both KRAS and NRAS, if we look, they are equally distributed. BRAF, however, is predominantly right-sided tumor. And other, we do not know their significance as of now today. So another question is, which is important, how are biomarkers detected? Traditionally, we detect by IHC on tumor markers or by RT-PCR or by doing FISH testing. But on liquid biopsy, by doing circulating tumor DNA or cell-free DNA, it has opened a vast number of mutations which we can pick now. So the biomarker profile is also changing. So in metastatic colorectal cancer, there are many drivers, but the actionability is very limited because of the availability of the medicines, or we do not know what role they play in the cascade of carcinogenesis. So there are different genomic markers in CRC. As I said earlier, it is a very heterogeneous group. So the important biomarkers which are useful for us in our day-to-day practice. If we look at the different pathways, the most common pathway is the chromosomal instability pathway, which constitutes about 80 to 85% of the cancers. So here the RAS mutations are common. In the SIM pathway, BRAF mutations are common. MSI pathway, we all know, it may be a part of Lynch syndrome or it may be sporadic. The MSI testing we do, and MSI usually it is high. So if we look at in a nutshell, in a concise form, what are the mutations that are meaningful to us today, which have a clinical relevance? One is the RAS and RAF. We can see almost 50% of the tumors are RAS mutated. And another 10% are BRAF mutated. We know if the tumors are RAS or RAF mutated, the EGFR inhibitor response is very poor. Then the other mutations in the RAS is newer RAS, and KRAS is also emerging. Then MSI we know is present in 5% of the patient, and it is the 40% of people who have wild type RAS and RAF mutations. Then HER2 new again is an emerging marker and has a therapeutic value, and it plays a role in predicting response to EGFR inhibitors also. So if we look at the NCCN, definitely they suggest to do KRAS, NRAS, and BRAF testing. Both in KRAS, extended testing should be done for the exon 2, 3, 4, same for NRAS, and BRAF should be done. In the majority, usually KRAS and BRAF and RAF mutations are mutually exclusive to a larger extent. Then again, we need to be testing the MSI. So there was two questions in the chat box. IHC for MSI, how much we can detect. Usually the concordance rate between the two is very good. And the other is, what is the significance of MSI? That we'll also discuss in the localized setting and in the metastatic setting. In the stage 2 MSI, it forms a good prognostic marker, but it also tells us the patients may not benefit from 5-FU alone adjuvant therapy. So HER2 new testing, again, we need to know. Then NTRK fusions, which are coming up in big way. Just briefly, the RAS mutations, we know in approximately 47-48% of the colorectal patients, they harbor mutation in the RAS gene. RAS basically is a downstream signaling pathway. If RAS is mutated, the upstream pathways, they may not work. The inhibitor therapies like cetuximab, panitumumab, they may not work. So that we know it is present in approximately 50% or 48% of the patients. Basically, RAS is a predictive biomarker also, not only prognostic, it is predictive also. For determining the efficacy of anti-EGFR therapy, we know if the mutations are mutated, the response will be not there. So BRAF, again, it is present in approximately 5 to 10% of the colorectal patients. Most majority of the mutations of BRAF are V600E. And otherwise, non-V600E mutations are also there. But what is their exact role? Whether presence of non-V600E mutation is equivalent to the mutation being not there, we do not know. But they have a very typical way of spreading. They have very high rate of peritoneal metastasis and less of lung and liver limited disease. Again, it is a downstream signaling pathway. If the tumor is getting activated here, the upstream pathways may not work well. So as I said earlier, the BRAF mutated tumors are usually right-sided, elderly, and they have a unique spread to spread in the peritoneum. They are usually mucinous, high grade, and present at advanced stage. And this we can discuss in subsequent. Then MSI high. This is a very important thing which we need to know both in the localized forms and in the advanced setting. So 3 to 5% is hereditary, and to 10% of the people they have sporadic. Out of 100 people, approximately 15% patients may have MSI tumors. Otherwise, majority are microsatellite stable tumors. So what happens in MSI is basically there is a defect in the repair of DNA. So the mutations keep on accumulating. So the more the number of mutation, more is the new antigen load. So more the new antigen, more is the chance for immunotherapy to work. That is the significance of MSI in the metastatic setting. So tumors usually which can be suggestive of MSI high, age less than 60, they are usually right-sided tumors. They present in multiple synchronous or metasynchronous colorectal cancers. Usually they have a typical histology of medullary or mucinous type. There are a lot of tumor infiltrating lymphocytes, which Dr. Pasricha can tell in a better way than us. Usually they are poorly differentiating. But poorly differentiating and MSI high, they negate each other. So basically this we have discussed. So the MSI high tumors in colorectal, they have poor response to chemotherapy regime, usually if given like 5-FU alone, and worse prognosis for patients with metastatic disease because repair mechanisms are deficient. But they open a scope for immune modulation. Then another thing is there. So even if the patient is MSI low, is there a possibility of it being tumor mutational, basically having neoantigens high? Yes, there is a possibility. There are different subgroups. So other important which is emerging is HER2 and NTRK. HER2 amplification is present in approximately less than 5% of the people. It is usually present in people who are wild type KRAS. And like breast cancer, this is not a hereditary germline mutation. It is a somatic mutation only. It is more common in left-sided tumors. It is again leads to activation, leads to proliferation, apoptosis, and survival of the cells. So blocking this prevents all this. So NCCN recommends this in patients who have stage 4 colorectal disease. And we can check it either by ISC or NGS panel or by doing FISH studies. The important emerging factors are the NTRK fusions, which is the tropomyosin receptor kinase receptors. It consists of transmembrane proteins, and they have their own receptors, though the the frequency in colorectal cancer is very low. So it constitutes only less than 0.5% of the cancer, but they form a subset where some type of manipulation is possible. So basically, it is not the mutation that tracks, but it is the fusions which make them which predicts the response to the treatment. So if mutation is there in the TRK, it will not help. But if there is a fusion, yes, there is a lot of partners are there which gives us chance to manipulate. And why we need to do it? Obviously, because it can predict our not only prognosticatively, but predicting the response to the therapy also. If RAS type is wild type, as of today, we are not doing HER2 testing upfront, but we should be doing if HER2 is amplified, then the response to EGFR inhibitors may be low. Then MSI, BRAF, we all know we have some agent to target them. So in coming days, if there is a co-occurrence of more than one targetable lesion, so novel options of second-line treatment may be there. So RAS mutation we know can predict response to EGFR therapy. BRAF is both prognostic and predictive. We have BRAF inhibitors coming in the scene now. MSI high. So how does it help the clinician? One, in helping us knowing that Lynch diagnosis of the Lynch syndrome, it is prognostic. Then no 5-FU efficacy if given alone in stage 2 disease, and anti-PD-L1 efficacy. This was the question asked in the chat box. So I think this answers that. So this we will see, because we know RAS-RAF are downstream pathways and EGFR works here at the surface. So if this is mutated or this is activating mutations, these therapies will not work. So RAF mutation, the EGFR inhibitor will not work. So people have done different studies, and in all the studies, to different proportion, these patients were present who had RAS mutation. So again, BRAF, again coming to BRAF, it is predicts a poor response. In multiple studies, it have shown the BRAF as a poor prognostic or a negative prognostic marker. So they are linked to shorter PFS, they are linked to shorter OS. So again, HER2 based therapies, the amplification though present in 5% of people and mutation in approximately 2% of people, it confers some degree of EGFR resistance. So, but we have a scope to manipulate them. Anti-HER2 therapies are there. So we have studies like HERACLES, which showed that combining trastuzumab with lapatinib in colorectal cancers, there was a response rate of 30%. And in my pathway studies, this has shown promising results where the trastuzumab was combined with pertuzumab. So we have something to manipulate. So there are studies like Mountaineer, My Pathway, Triumph, and Heracle studies here, which are predictive of this thing. Then NTRK and larotrectinib, again, we have something to manipulate. MSI high and PDL1. If MSI is high, we have anti-PD1 therapy in the form of Nivo and Pembro. And these are approved now in first line also. So different studies showing efficacy of PDL1. We will not go into detail today. So tomorrow there is a session there. So this is a upcoming marker about which we do not know yet. So tumor mutational burden, that is TMB, in colorectal cancer, it can identify about 3% of the patients of colorectal cancer who are MSS, who are microsatellite stable, but they may still be TMB high, thus giving us a scope to manipulate them with immunotherapy. So yes, there is a difference in survival. If TMB is high, the survival and the advantages, they differ. So just summarizing the somatic biomarkers and clinical implications, RAS, it is both prognostic and predictive. Frequency is approximately 40 to 45%. And the RAS wild type is good prognostic, and we can use RAS-RA wild type EGFR therapies can be used. And NCCN recommends BRAF, it is both prognostic and predictive. Frequency 10% approximately. Presence means worse survival. Yes, it is recommended to do the testing. So, but we can manipulate if VRAF mutation is there in combination with EGFR therapy. MET, we do not know the significance as of now. HER2 is predictive, though not prognostic, but may become prognostic for EGFR therapies. So the other are MSI, approximately 4 to 5% of stage 4 people have MSI high, and 15% of stage 2 to 3. So prognosis, again, we discussed 5FU resistance and scope to manipulate with immunotherapy. Then the rest, other mutation, PIK3CA, TIELs, POL3, as of now, we don't have standard recommendation to do the testing. So summarizing, so identification of predictive and prognostic biomarkers is important for advancing our understanding of and in cancer treatments. We need to identify more predictive biomarkers and improve drug development. Molecular subtyping grading and predicting the analysis for treatment is now well established in the routine pathology. The guidelines they recommend for the testing of MSI, BRAF, RAS, and ERV2, the morphological and molecular analysis may be integrated in the routine algorithm to direct us to therapies, and NGS wherever possible and feasible can be used for the treatment directions. With this, I'll stop here. Thank you very much. If you have any questions, I'll be happy to answer them.